Public Health will now come to order. The clerk will call the roll.
Click.
Here.
Campos.
Here.
Collier.
Here.
Jaton.
Here.
Johnson.
Here.
Jones of Harris.
Here.
Jones of Dallas.
Present.
Oliverson.
Here.
Quorum is present. Welcome back, everyone. We're going to now resume hearing bills. The chair lays out HB 4058 by Cortez and recognizes Representative Campos to explain the bill.
Good afternoon, Madam Chair Click and committee members. Thank you for the opportunity to lay out House Bill 4058 on behalf of Representative Philip Cortez. The Commissioner of State Health Services has established an advisory committee consisting of knowledgeable physicians and school employees to review the administration of epinephrine to a person experiencing an anaphylactic reaction. HB 4058 will add the responsibility of examining the administration of opioid antagonists to an individual experiencing an opioid-related drug overdose on school campuses. Specifically, the committee will advise on secure storage and training when handling opioid antagonists. Training is especially critical for school personnel or volunteers, so HB 4058 will require rules to be made regarding the logistics of administering the opioid antagonists. The training must also include information on how to recognize an opioid overdose, administer the medicine, implement emergency procedures, and dispose the opioid antagonist after usage. For higher education institutions, the opioid antagonists must be accessible throughout the campus, and any related information should be included in both student handbooks and school websites. This bill will require the institution to create a report within 10 business days of using the opioid antagonist, which will be sent to the physician who prescribed the medicine. Lastly, HB 4058 will ensure schools receive standard liability immunity from suits if they result from taking action or failing to act. HB 4058 will save lives by simply making opioid antagonists accessible and creating clear guidelines for administering the medicine to an individual suffering from a severe opioid-related drug overdose. With medicines such as Narcan being over 90% effective, it is now easier than ever to prevent needless overdose deaths. Expanding these opioid antagonists to schools must be a top priority. We look forward to working with Madam Chair Click and the committee members to see this legislation through. I respectfully ask for your favorable consideration. Thank you, and I reserve the right to close.
Members, questions? Okay, we'll
Thank you, Madam Chair.
begin our public testimony and reserve your right to close. The chair calls Paula Blackman. Up next on deck will be Rebecca Harkleroad. And I show that you're registered as Paula Blackman, and you are representing the city of Dallas and yourself. You're a council member?
Councilwoman, yes, thank you.
And you are for the bill.
Good afternoon, Chairman Click and members of the committee. My name is Paula Blackman, and I serve as the District 9 Councilwoman for the residents of the city of Dallas. On the behalf of the city of Dallas, I'm here testifying in support of HB 458. As a city leader and a mother, I want to thank Representative Cortez and many others on this issue for their leadership. HB 458 allows Texas schools and higher education institutions to maintain trained personnel and volunteers for the purpose of administering opioid antagonists. It also mandates that each higher educational institution adopt and implement policies to govern the use of opioid antagonists and mandate proper personnel training. It is common sense measure that will save lives, making opioid antagonists such as Narcan available in our schools. It will help decrease our overdose deaths, not only in Dallas, but in Texas. Our city is working hard to get this life-saving treatment into the hands of our first responders as this crisis has taken the lives of our children. I have a friend whose son did pass from an opioid. You know, it was how you had the discussion earlier. It was a poisoning. And they live in my district. And many of you have served on council, and you get these alerts that happen in your district, and I knew the address, and I knew it right then. I have 3 boys. It scares me. We have one in college, and we have these conversations. So having this on campuses and in our schools will save lives. We are now working with our own school district through a strike force that have allowed Dallas ISD to have Narcan on their campuses, and they're working with our DFR to train individuals. It is an important step in responding to the opioid crisis in our schools and in redirecting resources where they are most needed. And I hope that as you're going through all these bills, that you remember Martin, who passed, my son's friend, and do something. And so with that, I'm happy to take any questions, comments, suggestions.
Questions, members? Yeah, I would encourage you, I've spoken at a number of schools recently, parent groups, and when I do that, I teach them how to use Narcan. And there are a lot of great online resources, videos, in how to do it, in, you know, what the proper indications are and so forth. And that's something that somebody could use now, not after this bill becomes law.
Right. And next week, we are working, having a big DISD at one of the schools that's had some situations. And it's a 3-hour morning session of just understanding, helping parents understand and helping kids understand that Snapchat pill is not what you think it is. And we're working with our health provider in Dallas County and getting information out. But you're right, education and awareness and understanding is what we have as our best weapons to defend this.
You know, in some of those locations as well, they may have enough to administer 2 doses. Well, in
Those
some
2
of these,
doses can save.
you're absolutely, they
It's
can
time.
save, but frequently in a school setting,
We need more.
it's multiple students at a time
Right.
that are overdosing.
Right, and we're working with our opioid funds that we're getting. We are working to work with our partners and making sure they have the supplies, not only just our first responders, but in situations such as our homeless community, even in our libraries. We know that, why would you have in your, it's like put it everywhere. So I do applaud this legislature, this session, for taking this on. It's not something easy to talk about, but it's something that has to be talked about.
Thank you for being here.
Thank you.
Rebecca Harkleroad, followed by Shannon Jackett. I show you as Rebecca Harkleroad. You're representing the Texas School Nurses Association or organization and yourself, and you're for the bill. Is that correct?
Yes, ma'am.
All righty, you may begin.
Yes, my name is Becca Harkleroad. I'm a registered nurse, a nationally certified school nurse, and advocacy chair for Texas School Nurses Organization. And like you said, I'm here in favor of this bill. When we talk about the opioid crisis, lots of folks are picturing the widespread misuse of prescription medication. This is happening, and it does lead to dependence, addiction, and overdose. But the crisis we're seeing right now that you guys have heard so much about from so many families today, it's killing more young people than ever before. It's even more dangerous. Fake pills laced with fentanyl have flooded the black market in recent years. They're made to look like other medications that young people often misuse, like Adderall, Xanax, Valium, even pills that are opioids, like prescription OxyContin, are also being laced with fentanyl. because they're so frequently sold through social media. We've heard so many times about the Snapchat pill market, right? Because they're so frequently sold through social media. Young people believe that if they're getting the expected pill, because it looks like it, right, from a trusted friend, the assumption is that those pills are real and they're safe. And it's difficult, if not absolutely impossible, to distinguish the real pills from the fake just by looking. You guys have pictures in front of you, and I printed it out larger here. To be able to spot the real versus the fake, it's almost impossible. As little as 2 milligrams of fentanyl can kill a person. For context, those little pink packets on your table at a restaurant contain 1,000 milligrams of sweet and low. We know that raising awareness through education and prevention efforts like you were just talking about are effective tools, and they help dissuade young people from taking the risk of getting fake pills. We're working hard on that, but there's more that can be done. This life-saving medication that we've talked about this morning and now this afternoon, called naloxone, known on the market as Narcan, is designed to reverse the effects of an opioid overdose, including accidental ingestion of fentanyl poisoning. School nurses are trained to recognize the signs and symptoms of a suspected opioid overdose. We should also be equipped with this medication to be used in an emergency at school. It has already proven itself to be the difference between life and death at schools across Texas. Just like Chair Click was saying, a lot of schools are equipped with maybe one box, right? 2 doses. But what you saw and what you're talking about multiple kids having pills from the same provider, going down at the same time or on the same day, and also because these are unregulated doses in these fake pills, you know, 1 squirt of Narcan is supposed to counteract a prescription level of fentanyl, but we have had kids, even just in a school district just south of here, that required 7 doses of Narcan just to get to breathing on their own, and that didn't happen until EMS arrived. So with that in mind, obviously, I encourage you to vote in favor of this bill, and I'll take any questions you might have.
Questions, members? Thank you for being, oh, I'm sorry, Representative Jones.
Sure.
I was gonna say that a friend of mine's son died of it last year. And another of my friends who's an adult, so he was a high schooler. Another of my friends who's an adult has a professional, and she thought it was prescription, and she just sort of happened to mention it to me, that it's a prescription, and they were gonna give her the Adderall. And I was like, what you mean? You're gonna get it, he's reliable. I think she said she's reliable. What do you mean she's reliable? It's not a pharmacy, and you just don't know. So there are people, even more than just kids, who think because that there's a prescription drug, that they're just getting the prescription drug. And then I had to explain to her that a doctor needs to prescribe it, and different people can use different, I guess, quantities of whatever. And so just because it works for another person doesn't mean it's going to work for you, and it could be laced with something. So I think this is important. And what's so dangerous about this is it just doesn't look illicit.
Right,
It
absolutely. And like I said, especially for kids and adults even, right? You get a pill and it's from a trusted source, right? And it looks like the real thing, so you just assume that it is.
So I made a promise that she wouldn't do that anymore. I think she's trustworthy, so anyway, so yeah,
Good.
I'm glad to support.
Good, thank you for your time.
Any other questions, members? Thank you.
All right, thanks.
Next on board is Shelley Ramos.
Oh, Shannon Jaquette is coming up.
Sorry. Shannon Jaquette, Shelley Ramos, and then Laura Colangio.
Good afternoon. My name is Shannon Jaquette, and I am the Policy and Education Analyst at the Texas Catholic Conference of Bishops, and I am testifying in support of HB 4058. The TCCB accredits 231 Catholic schools across the state. We serve about 63,000 students, and we welcome this legislation as it allows our Catholic schools to implement a policy that would potentially save the life of a student, faculty or staff member, parent or visitor to our campuses or at an off-campus event. We've heard some alarming statistics. We know this crisis is spiraling out of control. Fentanyl is 100 times more powerful than morphine, 50 times stronger than heroin. And according to the Department of State Health Services, provisional data indicates that there was an 89% increase in overdose deaths from 2020 to 2021 here in Texas. The fact that other substances are being laced with fentanyl and people are ingesting it without their knowledge is cause for serious alarm. And it's important, I think, as we talk about education and awareness, to destigmatize Narcan, because it sounds really scary, and like a professional DEA agent would be the one who would have to administer something like that. But naloxone is actually easy to administer. It can come in a nasal spray. And this is a simple solution to a life or death situation that requires less training than CPR or even the administration of an EpiPen. So we appreciate Representative Cortez thinking about our private and Catholic schools and allowing us to adopt a policy if we so choose. And we look forward to the passage of HB 4058.
Question, members? Thank you. Shelley Ramos,
Yes, ma'am.
and I show that you are neutral on the bill and you are representing the Texas Education Agency. Is that correct?
That's correct.
Okay. Please begin.
I'm actually just here as a resource witness in the event that there were any questions.
Members, any questions for a resource witness? Thank you. You'll state your name and who you represent and your position on the issue.
Good afternoon, Madam Chair, Committee. My name is Laura Colangelo. I'm the Executive Director of the Texas Private Schools Association, and we are testifying in enthusiastic support of HB 4058.
And yourself?
And
represent-
myself, yes.
Thank you.
I represent the 920 private accredited nonprofit schools in the state. I think we've heard great testimony on why this is important, so I won't rehash all of that. But I thought that I would, maybe I missed the bill layout because I was sprinting from E2. So I'm not exactly sure if you went over all the committee substitute changes, so I thought I would touch on that a little bit. I'm a little sentimental and protective of this part of the education code because I worked with Representative Cortez many years ago to include private schools in the EpiPen portion of this. And since then, we have added asthma medication and now seeking to add Narcan. All of these life-saving medications are very important, and this non-mandatory allowing private schools to stock these and use these when they're needed, it works really well, and a lot of our schools take advantage of it, and we have saved lives through this. So a couple of the things in the committee substitute that were suggested was renaming the stock epinephrine committee to the stock, oh, is that not, you didn't lay out the committee sub? Okay, then I won't talk about that. How about, I would suggest that we could, since we are including all these medications, we could name the stock medication committee instead of just epinephrine. And we would suggest maybe making the higher education portion permissive and not mandatory. The most important part of this is the immunity from liability for the use of the drug or the lack of use of a drug, of these life-saving medications. But again, very important, and we are in support of HB 4058.
Questions, members? Questions? Alrighty, thank you. Is there anyone else wishing to testify on, for, or against House Bill 4058? Chair recognizes Representative Campos to close.
Thank you, Madam Chair and committee members. And I ask for your vote on behalf of this bill for Representative Cortez. Thank you, and I close.
If there's no objection, House Bill 4058 will be left pending. The chair hears no objection. House Bill 4058 is left pending without objection. The chair lays out House Bill 1683 and recognizes Representative Johnson to lay out the bill for Representative Wiley.
Thank you, Chairwoman Click. May I do it from the dais?
Yes.
Thank you for the opportunity to lay out House Bill 1683. House Bill 1683 would create an interstate compact for occupational therapist practitioners and occupational therapy assistants practitioners to practice in participating compact states outside of their own. This would also include telehealth. Currently, there are 20 other states that have already passed such provision, and Texas is among 16 currently considering this legislation at this time. This occupational therapy compact would have no fiscal impact on the state. It would also significantly benefit our military personnel and those that are transferred, and would enhance public health access to the state by strengthening services delivered through the state licensure system with occupational practitioners. Passing this bill would boost efforts to increase healthcare access, especially as we combat workforce shortages across the state. I thank you, and I reserve the right to close.
Thank you. Question, members? All righty, we will reserve your right to close. Chair calls Judith Joseph. I show you registered as Judith Joseph, and you're testifying on behalf of the Texas Occupational Therapy Association, and you're for the bill. Is that correct?
Yes, ma'am.
Please begin.
Thank you. It's National Occupational Therapy Month, by the way. Hello, Madam Chair and committee members. Oops, I do have something to give you. There you go. Thank you so much. My name is Judith Joseph. I am the Executive Director of the Texas Occupational Therapy Association, and I've been practicing OT for 38 years. I am testifying in support of House Bill 1683. I would like to express my appreciation for your consideration of the OT Licensure Compact. This measure began as a joint initiative between the National Occupational Therapy Association and our National Board Certification for OT. As of today, there are 25 states have enacted legislation for OT compacts, and 10 states, including Texas, have legislation pending. The OT compact has established commissioners, a governance committee, and rules are in the drafting stages, and the implementation of the OT compact is scheduled for late 2024. Healthcare licensure compacts have been in existence in the United States for over 25 years, with nursing being the first one adopted in Texas in the late 90s. They are intended to decrease the administrative burden on our increasingly mobile society while creating a framework for states to protect patient safety and uphold their licensing scope of practice and disciplinary standards. Compacts are not intended to nationalize any healthcare profession. To the contrary, they decrease regulatory burdens on both the individuals wanting to practice as well as the respective state licensing agencies. And as you heard before, for our military families, who are often the most mobile of our citizens, they provide the ability for a spouse to maintain a license and practice that occupation in the state that they live, that is a member of the compact, and seek compact privileges. To my knowledge, states who join the compacts have not seen a market uptake and issues with providers who may have been licensed in another state but seek privileges in a compact state. To the contrary, joining a compact allows a state licensing board the ability to access the database in real time to ensure no issues have arisen for a provider in another state. OT practitioners currently receive their initial license across the country by taking a national board certification exam by the National Board of Certification for OT, and then we're required to meet the established standards of state regulatory boards. Should Texas adopt the compact, practitioners seeking compact privileges will still have to follow the Texas rules set by the Texas Board of Occupational Therapy Examiners, enacted by Texas legislative process to serve and protect Texas consumers of OT services. Finally, compacts are a straightforward contractual agreement between member states, and they make sense for the taxpayers. Thank you for the opportunity.
Question, members? All righty.
Thank you.
Is there anyone else wishing to testify on for or against House Bill 1683? Chair recognizes Representative Johnson to close.
Thank you. On behalf of Chair Wally, I close and ask your favorable consideration.
If there's no objection, House Bill 1683 will be left pending. The chair hears no objection. House Bill 1683 is left pending without objection. The chair lays out House Bill 454 and recognizes Representative Smith to explain the bill.
Thank you, Madam Chair. Members, is it okay if I present from here? Thank you so much.
Certainly.
I appreciate the opportunity to lay out House Bill 454. I would just note to the members that this bill was passed out, I believe, unanimously in the 2021 session and died like many others over in the Senate. And we're going to give it a shot again. This actually was 2019, what I have on my bill book, but I could have sworn it was 2021. That it placed a requirement on multiple health care workers to obtain continuing education on human trafficking prevention. The Health and Human Services Commission was tasked with identifying and approving courses that would be eligible for providers. Texas physicians are mandated to obtain 24 hours of continuing medical education for each license period. We already require one of those hours to be in ethics and also mandate that physicians take 2 hours regarding opioids. The Texas Medical Board, which is the entity that regulates physicians in this state, has typically overseen matters related to continuing medical education. This is appropriate because TMB handles licensure and, more importantly in this case, licensure renewals of which CME requirements are tied. Thus, the bill moves the responsibility for overseeing the physician CME requirements to the TMB. House Bill 454 will ensure that the required course is approved and monitored in the same manner as all other CME courses required by the state through the Texas Medical Board. The language in the bill expressly focuses the requirement for this course on physicians with a direct patient care practice because those are the individuals we want to help with identification on trafficking victims. The bill also clarifies the goal of the education by removing the term prevention, as physicians cannot really prevent trafficking, but they can be aware and identify cases to intervene or assist. The short description has been changed to human trafficking identification, with a full description of identification and assistance of victims of human trafficking. Thank you so much for your consideration, Madam Chair. I believe there may be some testimony, and I reserve the right to close.
Great. We'll begin our public testimony. The chair calls John Carlo. Good afternoon, Dr. Carlo. I show you registered as John Carlo, and you're representing Texas Medical Association, Prism Health North Texas, and yourself. Is that correct?
That's correct.
And you support the bill?
Yes.
Thank you.
Thank you for having me here this afternoon. It is a pleasure to be here before you. My name is John Carlo. I'm a public health and preventive medicine specialist from Dallas. I'm speaking on behalf of the Texas Medical Association in support of House Bill 454. I'd like to thank Representative Smith for sponsoring this bill yet again. And as he mentioned, this is a refile from last session, which unanimously passed this committee as well as the House. This bill cleans up current statute to ensure the required physician CME course is approved and monitored in the same manner as all other CME courses as required by the state through the Texas Medical Board by transferring responsibility for the course away from the Texas Health and Human Services Commission to the TMB. This bill better aligns these requirements and expedites review and the approval of new courses as they become updated. Additionally, if only one course is available, the bill would not require physicians to repeatedly take the same identical course. We thank you for taking these steps to improve the process that ultimately improves physicians and our practice for our patients. And we appreciate to be here today and happy to answer any questions. Thank you.
Questions, members? Ready. Thank you. Is that it? Is there anyone else wishing to testify on or against House Bill 454? Chair recognizes Representative Smith to close.
Thank you, Madam Chair. Appreciate your time today, and I close.
If there's no objection, House Bill 454 will be left pending. The chair hears no objection. House Bill 454 is left pending without objection. The chair lays out House Bill 667 and recognizes Representative Johnson to explain the bill.
Thank you, Madam Chair, and if I may present from the dais, there is a committee substitute for this bill. And music, you all may remember last session, you actually heard a similar bill on music therapy to require license. That bill did not make it through the Senate, and so again, we are trying to give this another opportunity at getting this completed. Music therapy, if you all went to the Texas Medal of Arts, may have seen one of the award presentations that was done for Methodist Hospital. This is a specific treatment that can be done for those who are suffering from stress or trauma-related mental health conditions, and individuals attempting to provide music therapy treatment interventions without formal training risk doing harm to people with fragile neurological, physiological, and mental health conditions. Passage of this law would make Texas the 11th state in the nation to regulate this profession. House Bill 667 would ensure that every music therapist in Texas is licensed to provide appropriate care and to be able to effectively provide treatment to patients with mental health conditions and trauma-related services. Madam Chairwoman, we do have a couple of witnesses to provide additional testimony on this bill, and I would ask for the right to reserve to close.
Members, any questions for Representative Johnson? Okay, we'll begin our public testimony. The chair calls Jennifer Townsend. I show you registered as Jennifer Townsend, and you're representing Houston Methodist and yourself, and that you support the bill.
Yes, that's correct.
Okay, you can begin your testimony.
Hello, Chair Click, Vice Chair Campos, and esteemed members of the Public Health Committee. My name is Jen Townsend, and I'm here representing the Center for Performing Arts Medicine at Houston Methodist, as well as myself, to testify in favor of House Bill 667, authored by the Honorable Ann Johnson and co-authored by, I want to say it right, Teton, I think, is how you pronounce it. I've been a music therapist for 18 years, and during this time, I've used music therapy in the medical setting across the lifespan, from infants in the NICU to patients at end of life. A board-certified music therapist can provide an incredibly diverse array of benefits for patients of many types. For instance, at Houston Methodist, you can find a music therapist working with patients in our psychiatric unit, using music to modulate moods through individualized playlists. Or you may walk by the ICU and see a music therapist assisting with mechanical ventilation liberation by providing rhythmic entrainment, which allows the patient to align their respiratory rate with the rhythm of the music and maintain a steady and optimal breathing. You might also hear a therapist singing an original song written by a young daughter of a dying patient as they have their final visit. In addition to these examples, music therapy can be used in the treatment of cancer, sickle cell anemia, depression, post-traumatic stress disorder, anxiety, and autism, just to name a few. It is also used in pain management, which can encourage alternative treatments for the use of opioids. Former U.S. Representative Gabby Giffords lost her ability to speak after a gunshot wound to the left side of her brain. Because singing originates in the right brain, patients can learn to communicate through music, then can gradually become regular speech patterns. It is evident that music can be a powerful source of rehabilitation and healing for a variety of reasons. However, if provided without the training and knowledge, harm can be done. For example, because music can be associated with strong memories, some patients experience distress if they are exposed inadvertently or otherwise to a specific type or piece of music that elicits such a response. This is particularly important for Texans with mood disorders or autism. Music therapy can involve playing instruments, which require specific movements, If a patient underwent surgery and is in the recovery process, the patient will have parameters for the types of physical movements they are able to perform. If the person attempting to provide music therapy is unaware of these types of restrictions, bodily harm can occur. These examples demonstrate both emotional and physical harms to patients, but financial harm may also occur. Untrained individuals attempting to provide music therapy may defraud patients and manipulate them into believing they are receiving quality care when a person is not trained to understand contraindications of music therapy service. Board-certified music therapists are required to comply with safety practices and competencies based on a national standard. These standards are rigorous and tightly tailored to the practice of music therapy. The passage of House Bill 667 would provide the framework for state-level oversight and is essential to preventing harm. Thank you.
Questions, members? Representative Smith?
It's very interesting. Thank you for the information. Are you board certified?
I am, yes.
Okay, and who are you board certified through?
The Certification Board for Music Therapists. It's a national credential.
National, okay. And what are the minimum educational requirements for that?
The minimum education is a music therapy degree, can be bachelor's or master's, dependent upon the accreditation from the American Music Therapy Association. That continues on with 1,200 hours of supervised clinical work before sitting for the board exam.
Interesting, okay. And do you have a master's or a bachelor's or what?
I have a master's.
You have a master's, and how long have you been doing this?
18 years.
18 years, wow, okay. Thank you.
My pleasure.
Representative Jones?
Thank you for coming. As a former athlete, I know about occupational therapy. I literally had no idea there was music therapy.
Yes.
But it makes sense, so I'm glad that you filed this bill, because I just remember when my grandmother was, before she died, she needed all this help doing stuff, that music was the one time she ever smiled. And she would sing "I'm a Little Teapot" all the time. So we sang it with her. So yeah, this is good. I had no idea. But thank you.
Absolutely. We work closely with our colleagues in other therapies, but music can be one of those things that lasts. It's ingrained in us, and it is processed through a different emotional route in the brain, and so it holds on.
It was actually the only time when my grandmother got older, she was incredibly frustrated about things she couldn't remember, things she couldn't do. And I mean, I remember when she would tell me stuff, and I'd be like, "Grandma, you just told me that." And she would just be so upset with herself. And we were really trying to figure out how to have her be happy, because when she was happy, everything was just great. And I just remember just the simple songs. It seemed like she went back to her childhood. And so we just sang it with her all the time. So I guess we were doing music therapy, we just didn't know it.
So the flip side is that if you sang the wrong song, she might get agitated. And then what do you do? So the music therapist is trained to understand not only how to predict and learn the music biography of the person, so that the music that's offered is most appropriate in the moment, but also to respond if the music has a negative effect.
Wow, who knew? Okay, thank you.
Representative Johnson? One of the things you mentioned earlier in your testimony was, in the patient that may be aphasic, that has some type of neurological problem, be it, closed head injury, stroke, whatever. For the benefit of the committee members, you were talking about they may be having trouble speaking, but they could sing.
Right, that's right.
Which is an important strength to be able to use to help them be able to speak. Is that true?
That's true, yes, yes.
I would think that it might actually speed their recovery some when you're finding new pathways for them to be able to communicate.
Yes, it can be more efficient in some cases.
Ready. Thank you very much.
My pleasure.
The chair calls Arif Panjou. Brittany Trinite. I see you registered as Brittany Trinite, is that correct?
Trinity.
Trinite, I'm sorry. And that you're representing yourself and that you're for the bill.
Yes, that's correct.
Alrighty, please begin your testimony.
Thank you. Hello, everyone. I'm a board-certified music therapist. My name is Brittany Trinite, and I currently serve mostly young adults in the Central Texas area. I see clients in-home, and these clients deserve a high standard of care across the board with all of their service providers. And music therapy is evidence-based and effective, and clients rely on it in order to maintain their health, their social health, physical, cognitive, emotional, all across the board. I have worked with clients in all different goal areas. House Bill 667 allows patients more assurance that they're accessing quality care, and it's already difficult enough to navigate the Texas healthcare system. So we want to be sure that the most vulnerable clients are receiving high quality care. This improves accountability for our profession as professionals and also for our clients. So as a board certified music therapist, I support this.
Questions, members? Alrighty, thank you very much for being here.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 667? Chair recognizes Representative Johnson to close.
Again, I was grateful for this committee's support of this legislation last session and would ask for your favorable consideration again this session, and I close.
If there's no objection, House Bill 667 will be left pending. The chair hears no objection. House Bill 667 is left pending without objection. The chair lays out House Bill 2235 and recognizes Representative Vinton Jones to explain the bill.
All right. Thank you, Chairwoman Click, Vice Chair Campos, and my fellow colleagues of the Public Health Committee. Many people in Texas think that HIV is not an issue, that the epidemic does not exist. But the truth is, tens of thousands of individuals live unknowingly with HIV in Texas today. According to the Texas Department of State Health Services, 12 people are diagnosed as HIV positive a day. Let me repeat that. 12 people are diagnosed as HIV positive a day in the state of Texas. HIV remains a persistent public health problem in our state. And while progress has been made in preventing and treating HIV over the last 4 decades, there is still much to do in our state if we are to end HIV once and for all, starting with making HIV testing more routine in healthcare settings. According to the United States Department of Health and Human Services, HIV screening is the first step in a status-neutral approach to prevention and care. Status-neutral HIV prevention and care is a whole-person approach to HIV prevention and care that emphasizes high-quality care to engage and retain people in services, regardless of if the services are for HIV treatment or prevention. House Bill 2235 will ensure that HIV testing is being offered, not required, to individuals receiving routine medical screenings. This includes obtaining consent and giving any individual the ability to opt out if this test is not needed. To be clear, this bill is not asking for HIV testing every time a person visits a doctor, but offering an HIV test during routine medical screenings like physicals and well-woman examinations. Currently, a medical provider does not always offer an HIV test as a standard of practice when conducting routine medical screenings. This leads to patients being unaware of their current HIV status, and the burden to determine their status is placed in their hands of patients. while many which are unaware of the high rates of HIV that remain in the state of Texas. HIV is not the death sentence that it was once in the 80s and 90s. We are living in a time where if people test negative, there are tools like pre-exposure prophylaxis or PrEP that can help those individuals remain negative. Patients who test HIV positive, like I did 15 years ago, can be linked to HIV care to reduce HIV-associated morbidity and mortality and take medications to become virally suppressed, preventing the ability to transmit HIV to their partners. This bill has unanimous support from the medical community, and I'd like to thank all of you on the Public Health Committee who have already signed on to support this bill, and also for the strong bipartisan support this bill already has on the House floor. We have several medical experts and witnesses who will be providing testimony for this bill. Members, if you have any questions, I'll be more than happy to answer any of them this time. And with that, I reserve the right to close.
Question, members? All righty. We'll reserve your right to close. Chair calls John Carlo. And up next will be Alan Murray. Good afternoon again. I have you as Dr. John Carlo. You're representing the Texas Medical Association and Prism Health North Texas and yourself.
That is
You're
correct.
in support of the bill.
Thank you. Honorable Chair Click and esteemed committee members, it is a pleasure to be here with you today. My name is Dr. John Carlo. I'm a public health physician from Dallas, member of the Texas Medical Association's Board of Trustees, and I'm the CEO of Prism Health North Texas, the largest community health center in North Texas providing HIV prevention and treatment since 1986. I'm honored to testify on behalf of TMA and PRISM in support of House Bill 2235, and I'd like to extend my personal thanks to Representative Jones for sponsoring this bill. Since the outbreak of the HIV and AIDS epidemic in the 1980s, we've made some remarkable progress. So much so that you might not think that HIV is a problem here in our communities. But HIV is still a public health threat, and we still have a great deal of work to do. New infection rates have not changed in Texas in the last 5 years. We still have 100,000 Texans living with HIV, and the number of people living with HIV that don't yet know is 13%. And we know that this total is even more important because more than 40% of all new HIV transmissions in the United States come from those 13% who do not know their status. Fortunately, the medication we can provide to individuals once they are diagnosed is highly effective, preventing transmission. Most individuals reach undetectable or untransmissible with successful therapy. This bill will reduce the number of individuals living with HIV who do not know their status, subsequently connecting these people to care and medication. This does not replace the risk-based testing that we are already doing, as well as public health communities around the state. It addresses those who would not have been found otherwise through these other efforts. Nearly half of every new diagnosis of people living with HIV had at least one medical visit within the prior year of diagnosis, and some patients had up to 6 medical visits in the prior 2 years prior to being diagnosed, representing a number of missed opportunities. Testing does not represent an additional burden on physicians or other healthcare professions. It basically says that anyone is getting anytime any routine test, such as cholesterol, heart disease, or diabetes, consider an HIV test. Consider it once for everybody ages 15 to 65. Regardless of risk, we do this already in pregnancy as well as routine blood screening. If someone's been tested once and there's no risk, they do not need to be tested again. If somebody has donated blood and you've been tested, you do not need to be tested again. Finally, this bill permits an opt-out testing, as well as there's no requirements on healthcare to test. It's about $7 a test, and it makes a huge difference. Again, thank you for the opportunity to be here today, and I'm happy to answer any questions.
Question, members? Dr. Carlo, I was visiting with a colleague recently that shared with me a story about a woman who was 55 years old, married, and was admitted to the hospital in very serious condition, and come to find out she was HIV positive and died. And nobody had tested her because her risk profile didn't match what you would typically expect. Is that pretty common?
Yes, unfortunately, as I've seen many patients that Still, to this day, we don't know. There's no risk factor. We have many people that come in to see us for the first time. They have no idea that they were even infected with HIV. And many times those late diagnoses really result in really worse health effects. You know, somebody living with HIV, completely treatable, but if we don't know about it, then there's nothing we can do about it. So unfortunately, these stories happen far too frequently.
Thank you. Dr. Alverson?
Yeah, Dr. Carl, I appreciate you being here, and I just want to acknowledge that, you know, that this is what you do for a living and you have for a long time, and I'm grateful to you that there are doctors like yourself that prioritize the care of folks who are living with HIV and AIDS, and I remember being a medical student back in the 90s, and it was a very different time. You know, we were kind of scared, and we were just getting the first protease inhibitors, and we were just thinking like, gosh, you know, maybe people won't actually die of this disease, and I wonder how long this will last. So, I mean, we've come a long way, and I think bills like this are important to me because I think we're finally shedding that stigma. You know, this whole business of having to opt in and, you know, separate consents and all that kind of stuff really sort of centered around this stigma that was associated with HIV, which I know you appreciate, and I remember, and we visited, Representative Jones and I visited about this many times, and I'm just glad to see us kind of putting that behind us and sort of treating this like any other communicable disease that could be screened for, that, you know, okay, it's not curable, but you can live with it, and we can get you to the point where you can't pass it on, but we got to know about it. So I just appreciate your work on this, and thanks for sticking it out with us so late to testify on this.
Thanks for allowing me to be here.
Yeah, good bill.
Thank you.
Other question, members? Representative Jones?
You'd mentioned a percentage of, you said something that infections come from, I guess, did you say 13%? Like how many infections come from 13% of the people that don't know? I missed the number.
40% of estimated transmissions that occur in the United States are from the 13% who do not know they're living with HIV.
Thank you.
Other questions, members? Thank you. Alan Murray. And then the next one will be Lindsay Lanigan. I show you listed or registered as Alan Murray, and you're representing yourself and you're for the bill. Is that correct?
That's correct.
Alrighty, you can begin your testimony.
Okay, thank you. Good afternoon. My name is Alan Murray. I'm here to testify in support of HB 2235. I am from Houston, and the Houston Health Department did a care continuum in 2019. 30,149 people were diagnosed with HIV in the Houston EMA, which is Houston and surrounding counties. I forget the exact names. And they also did a estimate, and it estimated 6,825 of those were living with HIV, but were not yet diagnosed. It's especially important to get people diagnosed because we know that if we can get into viral suppression, which in Harris County, we have a really good viral suppression rate for people that are in care. It's over 90%. We know that they can't transmit the virus, and that's huge. As a person living with HIV, I can certainly attest to the benefits of early detection. I was diagnosed in 2003, and I still had a very strong immune system. And my CD4 count was not, I mean, it was high, but it wasn't, up to the ceiling. And because of that, they started me on medications. Within 4 months, I had a normal normal CD4 count, and my viral load was undetectable, and I've been that way ever since. So it really, it does make a huge difference to get it. Too many people don't find out that they're positive until they've already had an opportunity to stick infection. that's how they get diagnosed. That's kind of scary. This bill will increase testing and awareness of their status. We can then get them linked to care and virally suppressed. I also just want to mention, I work on the Ryan White Planning Council in Houston. I have to be clear, I'm representing myself. I don't have the authority to represent them, but we work really, really hard to provide the best services that we can for the people who are living with HIV. That does no good if people don't know they need it. So I too want to thank Representative Jones for bringing this bill forward and ask you to support it. Thank you. Oh, any questions?
Questions? No, thank you for being here. Lindsay Lanigan.
Hi, good afternoon. Chairman Click and members of the House Public Health Committee. My name is Lindsay Lanigan and I represent Legacy Community Health. I am here to testify in support of HB 2235. Legacy is the largest FQHC in the state, but we actually got our start as a Ryan White Clinic in Houston. We have 2 locations, one in Houston and one in Beaumont, that are funded by the Ryan White program. And we work to ensure access to HIV prevention and treatment that is available and affordable for underserved communities. Legacy alone diagnoses hundreds of individuals annually with HIV. I did not know a thing about HIV before I started working at Legacy, but I've learned so much about the prevalence, the stigma, the barriers to testing that can lead to ending the HIV epidemic. I've also learned that HIV is still very much prevalent in this state and continues to spread on a daily basis. 12 people a day is something that we should all be aware of. And if you look at the heat map of where HIV is most prevalent, it's all of the southern states. They're bright red. So when I started asking questions to my providers about how the spread takes place, they told me many things that may surprise you all as well. Number one, HIV symptoms take years to develop and become known to the patient. So in most instances, symptoms do not show up for 3 years. So you would not know that you are transmitting the disease. And you wouldn't know because there's a huge lack of testing within the state. HIV is not part of the normal screening process. It's not a part of an STI panel. And so the patient in many rooms across the state has to specifically ask for an HIV test. And then HIV is entirely preventable at this point in time. There are medications that now you can take and you reduce the spread of transmission or the ability to get HIV by over 98%. So there's so much we can do, and testing during routine medical screenings is an important step to ending this epidemic. I am grateful for Representative Jones introducing and championing this bill, and I'm happy to take any questions.
Question, members? Thank you. Is there anyone else wishing to testify on, for, or against House Bill 2235? Chair recognizes Representative Jones to close.
All right. I just want to thank everyone for hearing the testimony for this bill today. I'm about to lay out another bill, so I will save my longer remarks for that. And with that, I close.
If there's no objection, House Bill 2235 will be left pending. The chair hears no objection. House Bill 2235 is left pending without objection. The chair lays out House Bill 3377 and recognizes Representative Vinton Jones to explain that bill.
I'm back. All right. So thank you again for this opportunity to lay out House Bill 3377. Currently, when a patient visits their doctor and requests to be screened for sexually transmitted infections or STIs, HIV is a test that is not included by default, and an individual must request an HIV screening in order for it to be conducted. I was surprised by this information when I started researching this bill, and as I have spoke to many members and stakeholders about this bill, many others were surprised that HIV is not a current part of STI testing. This leads to confusion because most individuals assume that an HIV test are included as a standard part of STI panels. There's an urgent need to end this epidemic and expand access and awareness to HIV testing. House Bill 3377 would ensure that an HIV test would be offered, again, not required, to individuals receiving a screening for sexually transmitted infections. This includes obtaining consent and giving an individual the ability to opt out if this test is not needed. Again, if we are to end HIV, it is important that patients are given the access and are offered HIV testing when being tested for sexually transmitted infections. Having HIV testing as a standard practice with STI screenings would help identify people living with HIV as early as possible and reduce the transmission to other Texans. Again, this is another bill, an HIV testing bill that has unanimous support from the medical community. I thank, again, my colleagues on the Public Health Committee who have already signed on to support this bill. And this is also another bill with strong bipartisan support already on the House floor. Again, we have several experts who will be testifying, and if anyone has any questions, I'll be happy to answer them at this time. And with that, I reserve my right to close.
Questions, members? All righty, we'll reserve your right to close and begin public testimony. Chair calls Alan Murray. Up next on deck will be Lindsay Lanigan.
Hello again. Again, my name is Alan Murray, and I'm here to testify in support of the bill. In the interest of time, a lot of it has already been said. I'll just add that as being part of the Planning Council, I have friends in the community that come and talk to me about testing and where to go to get tested and should I get tested. And almost all of them said, well, I had an STI test last year. I must be okay. I don't have to worry about it. And it's just not true. And people don't understand that. So this bill is particularly important because it's attached to people that are already getting tested for an STI. And with that, I will close.
Mr. Murray, I have here you're registered on behalf of yourself. Is that correct?
That's correct.
Okay, needed to make sure we had that straight for our records. Question, members? Thank you for being here.
Thank you.
Lindsay Lanigan. Up next will be Janari Fox.
Hi, hello again. My name is Lindsay Lanigan. I represent Legacy Community Health. I am here to testify in support of HB 3377. You heard my previous testimony. It's more of the same, but I just, having an HIV test as part of a standard STD panel, STI panel is going to be really important to reducing transmissions. So thank you, and I'll take any questions.
Questions, members?
Just real quick.
Representative Smith.
Thank you, Lindsay, for being here. Can you tell me, in connection with a sexually transmitted infection, how in the world would we not have HIV as being a part of the panel in the first place?
That is a great question, and I think that surprises most people. And what's actually harmful about it is most people, when they get the results for their STI panel, think they're clear. They absolutely think, great, clean bill of health, I'm done. And that is the one piece that is missing in making sure that we're protecting the public health of the community. So that's a great question.
Thank you.
Other questions, members? Representative Collier.
Thank you. I remember they used to do these programs called Know Your Status in the community, and whenever they did it, I would go get tested to show that I have faith in the process and I want to know my status. And one thing that I would hear people in the audience saying is like, I don't want to get tested. But I think the stigma attached to it is that it's a death sentence, and it's not. Because of the advances in science, you can live with a positive HIV result for years on end. And so like Representative Jones was saying, it can, the gentleman before, he was saying that it's undetectable, it can become undetectable.
Oh, absolutely.
You said that too, I think you said that too. And so I think that the messaging, we could, do better by raising awareness about why it's important to know your status, because it's not a death sentence. It's something that you know how to treat it, how to address it. And so I agree with you. I was just completely shocked, like Representative Smith said. But I feel like especially in communities where there is a high population of underserved people, we need to do better to raise awareness about the testing and making sure that people know their status.
Yeah, absolutely. And I will say there's been an advent of at-home testing as well. And so we want to make sure that if you receive a positive diagnosis at home, you are immediately connected with individuals that are able to give you that exact message. This is not a death sentence. This is something that can absolutely be managed, and a lot of times managed with a pill a day. There are 1-pill regimens that are really important as well.
Other questions, members? Representative Jones.
I just wanted to say, I think the brilliance of this bill is that you opt out of it, because there's some people that just aren't gonna say the words. So I think that's really, really, really important. And so I just wanted to thank my colleague with the same last name, no relation, for filing this bill.
Thank you.
Other questions, members? Thank you. Chair calls January Fox, followed by Rox Sadie.
Hello.
I show that your name is January Fox.
Yes.
And that you are testifying on behalf of Prism Health North Texas and yourself, and that you support the bill.
Yes.
All righty, thank you.
All right.
Please
I
begin.
appreciate y'all's time today. My name is January Fox. I'm the Director of Policy Advocacy and Community Engagement for Prism Health North Texas in Dallas, and I'm here to speak in favor of HB 3377. For the past 37 years, Prism Health North Texas has served the critical role of providing health care to individuals living with HIV in the DFW Metroplex. Roughly 30% of people living with HIV in North Texas receive medical care and support at one of our 4 health centers, and we see upwards of 5,000 unique clients per year. We support HB 3377 as one method to identify people who are unaware of their HIV status and immediately link them to the appropriate medical care and resources. I wanted to share some statewide statistics with you specifically from the Department of State Health Services. As of 2021, there are an estimated 123,117 Texans living with HIV. That's up from 119,838 in 2020. So we see on average a little bit over 4,500 new cases a year in Texas. That's been consistent since 2012. Only 102,800 of those have received a diagnosis, and only 77% were in care. HB 3377, which includes routine HIV screening and an STI panel, may have the greatest impact on Black women who are disproportionately affected by HIV. Of the 7,000 new cases, and this is in the United States, not Texas specifically, of the 7,000 new cases in women in 2019, 54% were Black, over 50%. Over half were between the ages of 25 to 44, years where reproductive and sexual health are especially important. Texas law requires healthcare providers to test pregnant people for syphilis, HIV, and hepatitis B at their first prenatal visit. Let's extend this to other routine visits where screenings for STIs are standard of care. My first HIV test was when I was pregnant with my first child. Giving birth to a healthy baby was my primary goal, so I thought nothing of the test as I wanted to rule out any possible risks. I have continued to see my primary doctor once a year for a checkup, which includes testing for numerous STIs. When she first asked if I wanted an HIV test as well as the STI test, I was surprised to learn. Also, it's kind of the theme of this, surprised to learn it was not already included along with syphilis, gonorrhea, HPV, and others. Having worked in public health for over 20 years, I always say yes to the test. The CDC recommends being tested for HIV once a year. Studies show that the earlier people know their status and begin treatment, the more they will benefit from a long, healthy life. Treatment of HIV has become much easier to manage with the introduction of once-a-day, one-a-day pills, and long-acting injectables that are administered once every 2 months under a doctor's guidance. When medications are taken consistently, viral loads become undetectable and HIV is no longer transmittable. Patients will have the opportunity to opt out of the test in written form or verbally. If a test is positive, a healthcare provider will provide the patient with resources that will link them to the appropriate care. The addition of an HIV test to a routine STI panel is a public health investment that eliminates preconceived notions of who is or isn't affected by HIV and quickly moves the newly diagnosed into treatment.
Your time's expired.
That's it.
Questions,
I'm happy for any
members?
questions.
Thank you. Rox Sadie. Alrighty. Is there anyone else wishing to testify on, for, or against House Bill 3377? Chair recognizes Representative Fenton Jones to close.
Thank you so much, members, for taking the time to hear not only this bill, but both bills. I want to say that it brings me an immense amount of pride as a person who's been living with HIV for the last 15 years to be able to lay out this bill. HIV testing is very important, and we have always seen Texas to be at the forefront of addressing the HIV/AIDS epidemic. And I just ask for the support of the members of this committee to continue that very important work. I thank you very much, and I close.
If there's no objection, House Bill 3377 will be left pending. The chair hears no objection. House Bill 3377 is left pending without objection.
The chair lays out House Bill 4166 and recognizes Chair Click to explain the bill.
Thank you. Chapter 442 of the Health and Safety Code lays out a process by which certain prescription drugs can be donated. Currently, under this section, only prescription drugs that are in individual blister packs can be donated. HB 4166 would allow unopened, sealed, tamper-evident bottles of certain medication to also be donated. After filing, I did receive feedback requesting container to also be added to allow inhalers to be donated. I've requested a committee substitute to add this word, but don't have it back yet. This does not remove the existing inspection process required in Chapter 442. Bottles are allowed in other states with successful redistribution programs. We do have a witness here today who works in the area of drug donations. I'm open for questions, reserve the right to close. You know, this legislation that would allow drug donation, I worked with Dr. Sheffield on back in 2017. And the program is really not functional, and we think with the addition of this and a few other measures that it will become a functional program for those that are uninsured and underinsured. So,
Thank you, Madam Chair. Are there any questions for Chair Click? If not, then we'll proceed to testimony. The chair calls Jack Shafit. Mr. Shafit, we have you registered as Jack Shafit, representing MediCircle and yourself, and you're testifying today for the bill. Is that all correct?
My name is Jack Schaefer.
Okay, all right, we have it It was ending in a T, so we have your permission to correct that?
Yes.
Okay,
I apologize.
thank
That might
you.
have been my typo.
That's no problem. We'll get it corrected. Please proceed.
Good afternoon, Chair Click and other members of the committee. Thank you very much for the opportunity to speak today. My name is Jack Schaefer, and I'm the CEO and a co-founder of MediCircle. MediCircle is a pharmaceutical redistribution company that has been operating in the space for 3 years. I'm testifying before you today on behalf of MediCircle in favor of the proposed bills regarding the expansion of the drug donation program. I, along with the team at MediCircle, are very appreciative of the changes made with these bills and are excited about the new opportunities to help even more Texans afford and access their life-saving prescriptions. I'm more than happy to answer any questions that you may have. Thank you.
Thank you for being here today, Mr. Schaefer. Are there any questions of the witness?
I have a question. Chair Collier.
Thank you, ma'am. Sir, Chairman. Okay, so my question is about the bottles, because like one time I was given a prescription and I didn't take it because I was like, oh, I don't need any opioids or whatever after my surgery. I didn't take it, but they do this program where you can send it in this disposal bag and the city will take it back, I guess. Are you talking about those type of drugs? Because it didn't come with a seal.
Representative Collier, that's a great question. Thank you very much for bringing it up. The first point that I'd like to make is that we do not, the drug donation program does not apply to any opioids.
Okay.
We avoid all controlled substance.
If this was disposed, okay, so this one would not.
The entire drug donation program
Oh,
does
okay.
not apply to any opioids at all. They are completely ineligible for donation.
Okay.
In addition to that, you discussed what kinds of medications. They have to be tamper evidence sealed. I actually have an example, but I forgot to bring it up.
Can you go get it so I can see it, please?
Of course.
I'm sorry, I just want to see that.
This is just a simple bottle of Tylenol. The example I typically like to use.
Okay, it's tamper resistant, apparently.
Doing a great job.
Yeah, it's childproof.
And it's bolt-proof, apparently, is this
Oh.
seal. So they still have to be manufactured sealed in the original Tylenol bottle. For example, if it's Eliquis, in the original Eliquis bottle, Tagrisso bottle, with the seal still attached. If there's any tampering, according to the legislation passed and the drug donation program, and as regulated by the Department of State Health Services, a pharmacist must visually inspect it. If they see any tampering whatsoever, it's immediately disposed of to the proper authorities.
So is this going to like a Goodwill? Or is this going to the pharmacy? I'm just making sure we clarify things.
Absolutely. So a participating provider can sign up through the Department of State Health Services website. Participating providers are typically pharmacies or pharmacists. When the medication comes back to the pharmacy, they visually inspect the medication, and it can go back to patients who are either uninsured or underinsured and reporting a financial burden to afford the medication.
Okay, so then I come in, my child has a fever, uninsured, and you got one of those bottles there. You made sure that it's not expired, not tampered. And then the pharmacist can like re-gift it? Do they have to like fill out a form and say, this is going to this family or whatever?
Great questions, exactly. So if a patient is reporting financial burden and they have an appropriate prescription for the medication, the patient can say, I'm looking for alternative ways to afford these medications. The pharmacist can then bring up the alternative to have a medication that's been donated to the program. They have to fill out a waiver affirming that the medication was recertified, and then they can dispense it as if it was a normal medication.
So who's doing this now and in what state? Do you know?
Currently, there are 41 states with legislation. It has been going on since 2001, and there's been over $300 million worth of medication redistributed to date. Here in Texas, we have 6 participating providers, MediCircle of which is one. 2 were closed down during COVID due to fears, and I am not aware of what's going on with the other 3 pharmacies, but at MediCircle, we launched in January. We've recertified over $500,000 worth of medications, and we're helping patients now to date.
All right, sounds good. Thank you.
Thank you very much.
Any other questions for Mr. Schaefer? Thank you for your testimony.
Thank you very much.
Is there anyone else wishing to testify on for or against House Bill 4166? If not, the chair recognizes Chair Click to close on the bill.
Thank you, members. There are some specialty medication that can cost $50,000 and $100,000 a year. And if you're underinsured and uninsured, that is a great burden. This program will allow us to be able to put product that is otherwise unused and still sealed to the benefit of patients that do not have coverage. So with that, thank you, and I close.
If there's no objection, House Bill 4166 will be left pending. Chair hears no objection. House Bill 4166 is left pending without objection.
I don't care. You're fine.
The chair lays out House Bill 4331 and recognizes Chairwoman Click to explain the bill.
Thank you, members. Again, this is part of the drug donation program. Chapter 442 of the Health and Safety Code lays out a process by which certain prescription drugs can be donated. Currently, under this section, only individuals can donate prescription drugs. House Bill 4331 expands the definition to donors to include prescription drug manufacturers and healthcare facilities. This is an option for these facilities, not a mandate. Additionally, this does not remove the existing donation and inspection process required in Chapter 442. Healthcare facilities are allowed to donate in other states with successful redistribution programs. The inclusion of healthcare facilities as a donor also grants them protection under Section 442.057, which is a limitation of liability. Healthcare facilities will be free to act in good faith and implement facility-wide donation programs. By removing this barrier, there are more opportunities for providers to help patients gain access to affordable medication. I'm open for questions and reserve the right to close.
Members, are there questions for Chair Click? If there are no questions, we'll proceed to public testimony. Are there any witnesses? Oh, okay. Chair calls Jack Schaefer.
And I have to change.
We've already changed the spelling of your name on this one, so
I'm Jack Schaefer. Nice to meet you. No.
let's just confirm. Jack Schaefer representing MediCircle and yourself today testifying in favor of House Bill 4331. Is that correct?
That is all correct. Thank you.
Thank you.
Really just here to answer any questions that you may have or provide further insights. Thank you very much for your consideration.
Thank you for being here. Are there any questions of Mr. Schaefer? We really do appreciate you being here. Thank you very much.
Great. Thank you very much.
Is there anyone else wishing to testify on for or against House Bill 4331? Not, the chair recognizes Representative Click to close on the bill.
Members, HB 4331 just allows additional donors to consider the benefit of donating certain medications that would otherwise go to waste to be used by patients who need them. Thank you, and I close.
Thank you. If there's no objection, House Bill 4331 will be left pending. The chair hears no objection. House Bill 4331 is left pending without objection. The chair lays out House Bill 4332 by Chair Click and recognizes Chair Click to explain the bill.
Chapter 442 of the Health and Safety Code lays out a process by which certain prescription drugs can be donated. Currently, under this section, blister packs of certain prescriptions that have a few of the drugs popped out can be donated as long as the rest of the individual packaging is intact. Additionally, prepackaging medication is already allowed under the Texas pharmacy rules. HB 4332 would specifically allow donated prescriptions to be repackaged into brand new, sleeker packaging. This definition of prepackaging is taken directly from the Texas Pharmacy Rules, Section 291.31 definitions. The requirements for relabeling and records were taken from the Texas Pharmacy Rules, Section 291.94. This is existing practice in other areas of pharmacy. HB 4332 specifically codifies this into the prescription drug donation program. Additionally, the existing donation and inspection process required in Chapter 442 would still be in effect. I'm open for any questions and reserve the right to close.
Thank you, Chair Click. Members, any questions? If there are no questions, we'll proceed to public testimony. Chair calls Jack Schaefer. Again, we have your permission to correct the spelling, I guess.
Yes.
That's been handled, so we'll just confirm you're Jack Schaefer, representing MediCircle and yourself today testifying in favor of House Bill 4332.
That is all correct, and similarly to the last two, I'm here just to provide further insights if you have any questions.
Any questions of Mr. Schaefer? Chair Collier.
Thank you, Chairman. So this bill would allow you to take the prescription from the previous bill and repackage it. So you need these as a package, this bill with that.
Exactly. That's a great question and a great point. This is already done throughout the pharmacy industry. The best example that I can think of is PillPack. Are you all familiar with PillPack? They'll take multiple medications and package them so that they can enhance the adherence of the medication for the patient, because medication adherence is so important to make sure that the patient is taking them. There are ways that pharmacists can do that, and one of the most critical is through the packaging. Medication redistribution programs also want to take advantage of that, and most experts who look at the legislation currently here in Texas agree that that is possible. However, in speaking with other participating providers, they were wary of doing that for medications that were already dispensed and redistributed. This simply codifies it and protects it to make sure that all pharmacies and all participating providers know that this is allowed and that this is part of the program. The example you provided is one specific example in which medication, let's say it is a 28-day dosage, and we have 14 pills in one, 14 in the other. We can put them into a brand new packaging that is brand new so that the patient has nice packaging. Alternatives are, for example, if it's in that bottle, but it would be more advantageous for the patient to have it labeled as Monday, Tuesday, Wednesday, Thursday. Those are all examples in which this applies.
And I feel like it cuts down on confusion too, because if you say, oh, well, here's this one, and you put them all together, and then you got your 30-day supply.
Exactly.
Yeah.
That is the right idea. The point is bringing it all together to streamline the process and provide the patient with the best experience.
Thank you.
Thank you.
Any other questions? Mr. Schaefer, thank you again for your testimony.
Thank you very much for your time and your consideration.
Appreciate it. Is there anyone else wishing to testify on or against House Bill 4332? Not, the chair recognizes Chair Click to close on the bill.
Members, HB 4332 allows existing practice of prepackaging prescriptions to be used in the donation program, ensuring patients receive the highest quality product, medication, and experience. Thank you, and I close.
Thank you. If there's no objection, House Bill 4332 will be left pending. The chair hears no objection, so House Bill 4332 is left pending without objection. Chair lays out House Bill 3218 and recognizes Chair Click to explain the bill.
Thank you. Last session, we passed Senate Bill 1137 requiring certain medical facilities to disclose their medical prices with the purpose of enabling patients to shop around for the best price for non-emergent medical services. This bill builds on those efforts by requiring certain hospitals, freestanding emergency medical facilities, ambulatory surgical centers, and birthing centers to provide a cost estimate for elective inpatient admissions or non-emergency outpatient surgical procedures within 24 hours of being given a valid medical order for those services and a request from the patient for the estimate. The facility would be prohibited from collecting more than 5% above the estimated cost unless there were complications or change of diagnosis for the patient and there was a written explanation of the increase above the 5% cap. I am working on a committee substitute to address concerns about the short time frame in regards to weekends and some technical elements of the bill. In a nutshell, HB 3218 would require certain medical facilities to provide a requesting patient a cost estimate for an elective admission or outpatient surgery and prevent the facility from taking collection action against the patient if their billing was more than 5% of the original estimate, unless there were complications or a change in diagnoses. This is the next step of empowering Texans to shop for elective medical procedures and give them the ability to shop for the best value. I'm open for questions and reserve the right to close.
Chair Collier.
Okay, sorry. Chair Cook, thank you so much for bringing this bill because when I was diagnosed with breast cancer in 2016, I recall the hospital calling me for my pre-admission appointment, and I was informed that my procedure was elective, even though it was prescribed. And so a mastectomy would be covered because it's considered to be elective, and a person going in for that procedure under your bill would be provided with an estimate. And, you know, on top of everything else that is going on, but going into this ahead of time, knowing what the expectations are and the costs, I think this is very helpful information for patients because there's so many different procedures that are deemed elective that you and I, well, not you, you're a medical professional, but as myself, not a medical professional, would help me to understand what my responsibilities are. So thank you so much.
Any additional questions? Not, we'll proceed to public testimony. Chair calls Charles Miller. Mr. Miller, we have you registered to testify today as Charles Miller, representing Texas 2036, in favor of House Bill 3218. Is that correct?
That is all correct. Thank you, Chair Click, for offering this bill. As you mentioned, this does build off of the transparency efforts that began last session. I would say that those transparency efforts were focused mostly at institutional efforts in that they were machine-readable files, and they're not really accessible to individual consumers. And what this does is it enables an individual patient to get a meaningful price estimate to allow them to go around and shop. We have found that lack of access to this information is itself a barrier to care. In our surveys, we're finding that 1/3 of Texans are skipping care because they can't find out what it will cost them. And that jumps up to a shocking 57% among Texas moms. So while we understand that there are some technical issues to work out, this billing process is complicated. We look forward to working with your office and all the stakeholders on making sure those do get resolved. But this effort is important, and thank you again for bringing this bill.
It's great testimony. Thank you very much. Members, any questions? We appreciate you being here. The chair calls David Balat. Mr. Balat, thank you for being here today.
Thank you for having me.
We have you registered as David Balat, Texas Public Policy Foundation, in favor of House Bill 3218. Is that all correct?
That is all correct.
Okay, thank you. You may begin your testimony.
Thank you, Chair Clegg. Thank you, Vice Chair Campos. Thank you for members of the committee. It's an honor to be here. I think this is an important issue. My name is David Balat. I'm the director of the Right on Healthcare Initiative at TPPF. I'm in support of the bill. I'm also a former hospital executive and CEO of nearly 20 years, and I'm relying on my experience and expertise in the matter as well. HB 3218 builds upon existing law both at the state and the federal level. I'm going to repeat a little bit of what you've heard from Chair Click, but I think it bears repeating. Let me talk about state law first. Senate Bill 1731 from the 80th Legislature in 2007 states, the facility shall provide an estimate of the facility's charges for any elective inpatient admission or non-emergency outpatient surgical procedure or other service on request and before the scheduling of the admission or procedure or service. When I first heard about this, I was shocked because I was a hospital CEO at the time. Never came to my attention that we were to provide estimates within 10 days. Didn't know it. And as I was reading it, I thought, well, that can't be right. I need to go look at the bill. There are no consequences to not providing an estimate. So I'm not surprised by that. At the federal level, the good faith estimate found in the No Surprises Act, that requires facilities and other providers to provide estimates to uninsured or self-pay individuals in connection with items or services scheduled or upon the request of the uninsured individual. The bill being discussed today is simply an update on the good work of the 80th. It modernizes and improves upon the existing language to get it up to date and to serve patients and employers better. What does it do to empower patients? It really does two things. It empowers patients and it provides patient protections, because I can tell you that if there's an overwhelming sense of helplessness amongst patients when dealing with hospitals and hospital bills. It can be overwhelming, and I've had my fair share of dealing with patients. And I would say that that issue is largely why I do what I do now rather than doing what I used to do then. So what does it do to empower patients? A patient with a valid order must request the estimate. Nothing else happens if this isn't done. That's the trigger. So nothing else that we're talking about is an issue if the patient isn't making that request. The facility must provide an estimate within a period of time, and we're looking for a committee substitute for the 24 hours. If there's no change of diagnosis or complication, final bill is not going to be more than 5% of what the original estimate is. What does the bill do to protect patients and give them peace of mind? If the estimate is requested but not given to by the facility, so if I have a patient say, I want an estimate, and I end up having the procedure there, but they never give me the estimate, these are the things that will be the outcome. Number one, the patient's not responsible for their patient portion. Number two, they will not be sent to collections. Number three, not sent to the credit bureau. Number four, they won't be litigated against. This isn't the strong arm of government providing a consequence. This is a civil right of action on the part of the patient. And I've consulted with TLR, and this is something that they have no issue with. It was said all along that price transparency from last session was the first step. It was. This is the second step. It's important to understand that every hospital has a different methodology for billing. So being able to pick which CPT codes go with your certain procedure, nearly impossible for the average patient, nearly impossible for me. So this is providing pricing upfront that is meaningful, that can be used to truly shop. I'll leave it there. I can keep going on, but I'd rather just give you guys the ability to ask questions.
Really appreciate your testimony, Mr. Ballott. Thank you for being here. Are there any questions?
I have a question.
Sure. Vice Chair Campos.
Thank you. Hi, how are you? Just a question with regards to, with everything that's happened with COVID, we know that there's some hospitals that are, financially in the red. So is this a good time to introduce a bill like this? And how is it going to affect hospitals in Texas?
I'm glad you asked the question. I think, let me address that as two questions and maybe two answers. How will it affect hospitals in Texas? I think first and foremost, we should think about how is this going to affect patients in Texas, because that's who is currently hurting the most. I think that this is an opportunity for a lot of hospitals to be first to market in providing prices up front, because God knows that's what patients want. They want that transparency. If you look at the polling, it's 90%. Let's talk about the financials of the hospitals. There have been a Becker's, which is an industry report came out. State Affairs just came out with some research from Johns Hopkins that has shown that the financial reports that are showing negative profits for the hospitals really coming from places other than their patient care business. And I think it's important that if the hospitals are coming to you and saying, hey, we're in the red, to ask them specifically, is that due to your business of patient care? Because if you look into the financial records, you'll see that their unrealized investment losses are contributing to those red lines. Also, we've had a record building of buildings and purchase of capital equipment by the hospitals over the last 2 years. Depreciation and amortization are non-cash line items that contribute to the bottom line. So I think it's important to ask the right question when they're coming to you and they're saying, we're financially at a loss.
Okay, thank you for that.
My pleasure.
Any Representative Tinderholt?
Thank you, sir. So because I don't know your job, you said you were the CEO or what did you do?
I'm currently Director of Right on Healthcare with Texas Public Policy Foundation.
What did you do before?
I was a healthcare executive, hospital CEO. I did turnarounds of hospitals in various parts of Texas and southern Louisiana.
So obviously, I support customers knowing what costs are going to be. I think that's super important. Are there instances in your old job where diagnosis might not change, but something happened that would have changed the price? I don't know if it could be they had to use a different piece of equipment, or they had to bring in another medical professional they didn't expect because something, Or is 5% truly a fair number for the consumer and the hospital or the clinics?
Well, I think it's important that patients are aware of what happens up front. Now, in terms of changes that need to be made, that occurs in other businesses as well. And that's the cost of doing business, typically. Now, when doctors or physicians or medical professionals are credentialed as part of a hospital, especially those in a surgical function, they're providing something called a preference card. And on that preference card, it's everything that they need to conduct the work for that particular procedure. It's all the supplies, all the equipment, all the instrumentation, staffing, you name it. So there should be a good sense for what that cost is going to be, at least on a variable cost side, for that particular procedure.
Okay.
So if there are going to be exceptions, I would consider that to be the cost of doing business, and that shouldn't be the fault of the patient.
So it sounds like it's more it's a rarity that exception happens. It sounds like more like it's semi-cookie cutter the pricing should be. Am I semi-correct with that?
I would agree with that. I think that if there are more exceptions than not, I'd consider that to be a management issue, but that's my personal opinion.
Okay, well, thank you, I appreciate it.
Pleasure.
Chair Click.
Representative Tinderholt, in that there's provisions, sometimes when you go in and do a procedure, you find something you don't expect. And in the case of that, there's an explanation required if it's going to go above because of something unforeseen that is found when they go in and do a procedure.
Yep, she's showing me line 24, 5, and 6. So
right.
On page
So there are provisions for that.
Thank you.
Any additional questions? Thank you for your testimony. We appreciate you being here today.
Thank you all very much.
Is there anyone else wishing to testify on, for, against House Bill 3218? Seeing none, the chair recognizes Chair Click to close on the bill.
HB 32, this bill, allows healthcare customers to quickly find out what costs they would face for a given procedure, allowing them to search for the best value. Please give this your favorable consideration. Thank you, and I close.
Thank you, Chair Click. If there's no objection, House Bill 3218 will be left pending. The chair hears no objection. House Bill 3218 is left pending without objection.